It is flutter, sawtooth pattern.
Are you sure this is flutter or this is atrial fibrillation? How you are going to differentiate between two? The rate, atrial rate, is how much in flutter and how much in fibrillation. See, this is sawtooth appearance, multiple P waves. So this is fibrillation, atrial fibrillation, not the flutter. Flutter rate is up to 200 and fibrillation rate is more than 200. Is this clear to you?
Okay.
Okay. Now why this is not moving? So this is atrial fibrillation. Now, can you tell me what is this strip telling you? Quickly. This strip is showing normal PQRS complexes. So how much is the rate?
Around 60.
Around 100, ma'am.
Around 100. So this is the strip showing the sinus tachycardia, right? Now, can you tell me what this strip is telling you?
Atrial flutter.
This is atrial flutter because there are the limited P waves between the R wave. Now, what is this strip telling you? How much is the rate?
Sinus brady.
Sinus brady. Rate is?
Around 60, ma'am.
60. Very good. Now, this is again sinus tachycardia. Now, can you tell me what this strip is telling you? Premature atrial complexes. Can you make out normal PP interval? This is shorter PP interval, right?
Yes, ma'am.
So this is premature atrial complex. Now, what this strip is telling you?
Monomorphic VT.
This is ventricular
Tachycardia.
tachycardia. Now, this is long QT interval, prominent U wave. Prominent U wave is a sign of
Hypokalemia.
hypokalemia. Very good. Torsades pointes. Now, this strip is telling you what?
Polymorphic VT.
This is ventricular fibrillation because there is no clear-cut any complex. So, Vizare pattern. What is the treatment of ventricular fibrillation? Defibrillation.
Defibrillation.
Yeah, defibrillation. Now, what about this strip? This strip is saying what? ST segment. ST segment is elevated or not? In chest leads. This is the lead 2. Lead 2 is normal. So chest leads are saying some changes. So infarction and ventricular hypertrophy. Now what is this strip saying? See, ST segment elevation in all the leads. So global myocardial infarct. Now what is this? What is this? This is asystole. No complex at all, right? Now what about this? Sinus bradycardia with
Idioventricular.
What is this?
RBB pattern, RSR
RBB.
pattern.
Correct. What are the causes of RBBB? Pathological and physiological. Physiological are pathological are right ventricular hypertrophy. Pathological are what? Most of the time, right bundle branch block. Now, what is this? What is this? What is this?
LBB.
LBB, ma'am. Left ventricle.
Anterolateral myocardial infarct with LBB. Now, what about this? P wave, but QRS complex is not following. So this is first degree heart block, AV block. This is see in this lead 2. Again, absent QRS complex between the two P waves, right?
Yes, ma'am.
So this is heart block Mobius type 1. This is Mobius type 2. Right? There is no clear-cut regular pattern between the leads. Second degree AV block Mobius type 2. Now this is
Complete heart block.
heart block. So these are the few ECG tips which I wanted to tell you, and you should able to diagnose it if you know the conduction system well, and you should know the causes and treatment of all these ECG cardiac problems. Anything if you want to know from me, you are most welcome to ask. Should I stop sharing my screen so Aswant can start?
Yes, ma'am. Yes.
Okay.
If they have a question, they can always ask after the presentation.
No problem.
Am I visible, sir?
Yes, you are.
Start from class. Can I start my class, sir?
Yeah, please start.
Yes. Good evening. Today we're talking about antiarrhythmic drugs. So basically, arrhythmias are irregularities in cardiac rhythm, and it is important because they reduce cardiac output and may lead to ventricular fibrillation, which leads to sudden cardiac arrest. These drugs are used to prevent or treatment of irregular cardiac rhythms. Drugs can either be life-saving or can be pro-arrhythmogenic. Hence, should be cautiously used in treatment of asymptomatic arrhythmias. So what is arrhythmia? Arrhythmia is an abnormal automaticity or abnormality in impulse generation, conduction, or both. And these abnormalities are due to alterations of cardiac electrophysiology, which may happen due to ischemia, electrolyte and pH imbalance, mechanical injury, stretching, neurogenic, and drug influences like the antiarrhythmic drugs. So first, before that, let's know about basics about action potential. Action potential happens because of depolarization and repolarization with alteration in the ionic permeabilities of the sodium, potassium, calcium channels. There can be two types of action potentials: slow channels and fast channel action potentials. The slow channels are present mainly on the sinoatrial node, AV node, in Purkinje fibers. These are due to calcium currents and has higher threshold with less negativity and has a slow phase zero depolarization. These are has less overshooting and low amplitude, and also has a very slow propagation. The fast channel action potentials are mostly seen in atria, ventricles, and Purkinje fibers due to the sodium channels, and have a lower threshold with more negativity, has a steep phase zero depolarization, and has an overshooting of up to positive 30, and has a fast propagation of action potential. So these are 5 phases of action potential. Phase zero is a rapid depolarization due to sodium influx, and phase one is due to early or partial repolarization due to potassium efflux from cells, and phase two is a plateau phase due to influx of calcium, and phase three is a rapid depolarization due to potassium channel opening and potassium extends from cell, and phase 4 is slow diastolic depolarization from the returning up to the resting membrane potential, and the shape, cholestatics, and ionic permeability depend on the type of the cardiac cell. So this basically on the action potential. The sinoatrial node has the steepest phase 4 depolarization, overrides other cells with potential for automaticity. These are called the pacemaking effect, and other cells have pacemaker as well. But when sinoatrial node is depressed, or when their own intrinsic rate of depolarization becomes greater than the sinoatrial node, there becomes a latent pacemakers from the other cells. So mechanism generation of arrhythmias happen due to abnormal impulse generation, triggered activity, or after depolarization, and also due to abnormal impulse conduction. So the mechanism of action of the anti-arrhythmic agents happen on suppressing these mechanisms, either due to decrease the rate of phase depolarization, decrease the slope of phase zero depolarization, increase the duration of the refractive period, making resting membrane potential more negative, making a threshold potential less negative, and also abolishing re-entry before slowing impulses or conduction, converting the unidirectional block to bidirectional block. Classification of drugs is based on the Vaughan-Williams and Singh's classification. The class 1 drugs, commonly called sodium channel blockers, a membrane stabilizing action and blocks sodium, and a few as potassium channel blocker as well, act as a local anesthetic action as well. And class 2 drugs are the beta blockers. They have the anti-androgenic drugs like the propanol, esmolol, sotalol, acebutolol, and metoprolol. The class 3 drugs are agents which widen action potential. They work on the calcium channel blockers. Drugs like amiodarone, bretilin, dofetilin, and ebutilide are in this group drug. And class 2 drugs, sotalol, also has a minimal effect of class 3. The newer drugs are dronedarone, vernaculant, azimelite, and tedisamil are also is there in the drug. And class 4 are the calcium channel blockers, verapamil, and diltiazem drugs. Other drugs are the adenosine, digitalis, isoprenyl, atropine, magnesium, potassium, and ranolazine. So let's see about the class 1 drugs. Class 1 drugs are sodium channel blockers, and few also has potassium channel blocker action. These are use dependency property, and high frequency excitation effectively are blocked. Reduces maximum rate of the phase 0 depolarization, reduces rate of phase 4 depolarization, automaticity of cells, and suppresses automaticity of Purkinje cells and bundle of fish, thereby potentiating the sinoatrial node pacemakers. They are subdivided into class 1A, 1B, and 1C. And the class 1A have moderate decrease in the rate of depolarization of phase 0 and includes drugs quinidine, procainamide, diisopramidine, and morisicin. And class 1B has little decrease in rate of depolarization phase 0. They have and consists of lidocaine, phenytoin, mexiletine, and tocainate. And class 1C has marked decrease in rate of depolarization phase 0. Propafenone, flecainide, encanide, and morisicin. So these are the class drugs. And class A drugs are the oldest antiarrhythmic drugs. They block the action of open state sodium channels and has moderate delay in channel recovery, and also has suppression of the AV conduction and prolongs the refractoriness of the cells. Action is marked in high frequency arrhythmias, extinguish ectopic pacemakers, and abolish re-entry by converting unidirectional to bidirectional block. The drugs are quinidine, procainamide, diisopamidine, and morisicin. Quinidine is an isomer of quinine derived from cinchona bark. They have a sodium channel blocking action and cardiac antivagal actions on atrial fibers. These augment prolongation of effective refractive period, minimize refractive period disparity between the atrial fibers, and also cause depression of myocardial contractility. Hence, there is a failure in damaged heart. Other effects like fall in BP because of the mild alpha blockade effect and cardiac depression. There is decreased skeletal muscle contractility, decreased uterine contractility, induced vomiting and diarrhea, neurological effects like ringing ear, vertigo, deafness, visual and mental changes, synchronism can be seen, and also has anti-malarial actions. These are parental alternatives to quinine in falciparum malaria. The mechanism action is blocks open state sodium channels, atomicity and phase zero depolarization reduce, has minimal potassium channel blockade, leading to prolongation of action potential duration, moderate blocking recovery of sodium potassium channels, prolongs the effective refractive period, and high concentration leads to inhibition of L-type calcium channels. Adverse effects, the GID effects like nausea, vomiting, synchronism, torsades, sudden cardiac arrest or VF, idiosyncratic angioedema, vascular collapse, thrombocytopenia. And used like it's a highly toxic drug. It's not to terminate atrial or ventricular arrhythmia. It's used only to maintain sinus rhythm after termination of atrial fibrillation and flutters. Procainamide is an amide derivative of local anesthesia procaine. It is orally active. Sodium channel blocking action similar to that of quinine, and the difference is less effective in suppression of ectopic atomicity, contractility, and AV conduction. Minimal antivagal actions, no alpha blocking actions, but has ganglia blocking actions and high concentrations. Adverse effect. Adverse effect as GI effects, CNS effects, weakness, mental confusion, hallucinations in high concentration, CVS, rapid IV, it causes flushing, hypotension, cardiotoxic, toxicity points, and similar to that of quinine. That's hypersensitivity reaction leading to fever, rashes, angioedema, rarely aplastic anemia, agranulocytosis. Development of anti-nuclear antibodies is seen in 50% of patients, and one of the patients shows SLE-like symptoms. Uses IV for terminating monomorphic VT, treatment of WPW is reciprocal VT, prevention of recurrences of PF. Morrisism has a greater sodium channel blocking actions. Also, as a class 1C drug, less marked cardiac depression and CNS effects, and used to suppress ventricular extrasystoles and WPW arrhythmias. Increases mortality in post-MI patients. Class 1B drugs, these block sodium channels more inactive state than open state, do not delay calcium recovery. No action on AV conduction, action potential duration, effective refractive period, or QT interval. These include drugs like lignocaine, mexiletine, phenytoin, and docaine. So lignocaine is a local anesthetic, has as an antiarrhythmic commonly used in ICUs. It has a direct antiarrhythmic action when given as IV, has prominent blockade of inactivated sodium channels than the open state. It causes suppression of atomicity in ectopic foci without affecting atomicity of sinoatrial node. Suppresses enhanced phase 4 depolarization and partially depolarized Purkinje fibers. Antagonizes after depolarization in Purkinje fibers. The AV bundle, there's no change in phase 0 depolarization or conduction velocity. In Purkinje fibers and ventricles, action potential duration is decreased. Suppresses ventricular re-entrant tachycardia. So there is only unidirectional is converted to bidirectional, and depolarized or damaged ventricles, the action of the drug is significantly depressed. So hence minimally affecting only minimally affecting the normal ventricular fibers. There's no action on sinoatrial node or atrial fibers. Little change is there in cardiac contractility and or BP. No pro-arrhythmogenic potential is seen in the drug. No atomicity actions. Kinetic has high first pass metabolism, given only as IV. Action lasts for only 10 to 20 minutes due to rapid redistribution. Metabolism dependent on hepatic blood flow, and T-half is about 2 to 3 hours. This prolonged in case of congestive heart failure because of decreased volume distribution and hepatic blood flow. Adverse effects, dose-related neurologic effects are seen like drowsiness, parathesis, blurred vision, disorientation, nystagmus, twitching, and fits. Used only in ventricular arrhythmias. Very good in emergency like MI and cardiac surgery. Prophylactically in acute MI to reduce VF, and digital can be replaced in digitalis toxicity. Mexiletine is a local anesthetic, orally effective antiarrhythmic, resembles lignocaine, reduces atomicity in Purkinje fibers, decreasing phase 4 depolarization, increasing the threshold voltage. it also reduces rate of phase zero depolarization in ischemic Purkinje fibers, converting unidirectional blockade to bidirectional blockade. Class 1C drugs, these are the most potent sodium channel blockers. They blocks the open state sodium channel predominantly and prolongs the channel recovery. It has the longest recovery among the other drugs, and also delays conduction markedly. It prolongs the PR interval, widen QRS complexes, and also variable effect on action potential duration. Prominent action on His-Purkinje fibers and accessory pathway of conduction, retarding the anterograde retrograde conduction and bypass tract of WPW syndrome. High pro-arrhythmogenic potential can lead to sudden cardiac death. Propofenone, the sodium channel blocking, causes marked depression of conduction. Beta blocking action also seen in congestive cardiac failure and leads to congestive cardiac failure and bronchospasm. Occasional sinoatrial block is reported and as polymorphism. The metabolism variable on viability and THAPs. Adverse effects: nausea, vomiting, bitter taste, constipation, and blurred vision. Reserved drug for ventricular arrhythmias, reentrant tachyarrhythmias involving AV node, accessory pathway, and to maintain sinus rhythm in AF. Flecainide, it suppresses ventricular extrasystoles, ventricular tachycardia, WPW, and prevent recurrences of AF and PSVT. There is increased mortality in post-MI patient based on the CAS study, cardiac schedule trials, and reserved for resistant recurrent AF, WPW rhythm when not associated with congestive heart failure. Class 2 drugs, these are beta blockers, block adrenergic induced ectopic activity, slows the SA node conduction, decreases heart rate, prolongs PR interval, and slowing AV conduction increases effective refract period and prolongs the action potential duration. Pacemaker cells depresses the phase 4 depolarization. Propanol is a non-selective blocker. Regular dose causes cardiac adrenergic blockade and has antiarrhythmic actions. High doses like quinidine, like membrane stabilizing actions are seen. Sinoatrial node Purkinje fibers and ectopic foci decreases the slope of phase 4 depolarization automatically. In AV node, it prolongs the effective refractive period and delays conduction, as seen in this picture. Calcium-induced slow channel responses and after depolarization are suppressed and re-enter arrhythmias involving AV node abolished. IV administration for rapid action is and very useful in inappropriate sinus tachycardia, atrial and nodal extrasystoles provoked by emotions or exercise. In PSVT, there are 60% conversion chances there. So for controlling ventricular rate in AF and atrial flutter, highly effective in sympathetically mediated arrhythmias in pheochromocytoma and halothane anesthesia, and suppresses digoxin-induced tachyarrhythmias. Prophylactic to reduce mortality and post-MI cases. Sotalol is a non-selective beta blocker, has a prominent class 3 action, prolonged repolarization by blocking cardiac potassium channels. It has no actions on sodium channels. AV node, it delays conduction, prolongs the effective refractive period, and action potential duration is increased. Yes, decrease. Adverse effect, risk of Torsades pointus and contraindicating conditions where QT is prolonged. Very useful in polymorphic VT and for maintaining sinus rhythm in AF and atrial flutter. Esmolol, as a quick and short acting, is a cardioselective drug, very useful for emergency control of ventricular rate of AF and atrial flutter. For terminating supraventricular tachyarrhythmias, mainly used in the treatment of arrhythmia associated with anesthesia. The class 3 drugs, the potassium channel blockers, cause prolonged repolarization. The outward current potassium channels are blocked, and action leading to action potential duration is prolonged. Effective refractive period is prolonged, and tissue refractive period to stimuli even after full repolarization. Re-entry arrhythmias are blocked. The drugs are amiodarone, bretilin, dronderone, and vernaculant. The new drugs like azimelide and tedicimel. It blocks potassium channels and prolongs repolarization. Amiodarone is an amide containing highly lipophilic long-acting drug. It blocks myocardial delayed rectifier potassium channels, prolongs the action potential duration, QT interval, non-uniformity among fibers are reduced, and blocks inactivated sodium channels with relative rapid rate of channel recovery. marked in partially depolarized cells. They also block myocardial calcium channels and also act as a non-competitive beta blocking action. It has slows the conduction of electric current, and ectopic atomicity also is depressed. It has little action on sinoatrial node. When given as IV, it causes myocardial depression and hypotension. It also has low arrhythmogenic potential, so there's no reverse use dependence of action potential prolongation, and has multiple mechanism of action. Kinetics is an incomplete and slow oral absorption, has a slow onset of action, but on IV is a rapid action and accumulates in muscles and fat, metabolized by CYP3A4 and has the longest T half of 3 to 8 weeks. Adverse effect when given as IV causes hypotension, bradycardia, myocardial depression, and oral causes GIT during loading doses, GIT symptoms during loading doses, and skin causes pigmentation and photosensitization, and corneal microdeposits are seen, common on long-term use only, and on lungs it causes pulmonary alveolitis and fibrosis, at most serious dose-dependent effect. CNS causes peripheral neuropathy, causes shoulder weakness and pelvic muscle weakness, and thyroid inhibits peripheral conversion of T4 to T3 and causes goiter and hypothyroidism. Interaction, it reduces renal clearance of digoxin, warfarin, and has additive AV blockade when co-administered with beta blockers and calcium channel blockers, and enzyme inducers or inhibitors modifies their actions. Use is most commonly used as a drug and has a high and broad spectrum efficacy and less arrhythmogenic potential. Used in ventricular and supraventricular arrhythmias, WPW arrhythmias, resistant VT and recurrent VF, to maintain sinus rhythm in EF when other drugs have failed, and preferred for long-term prophylaxis. Beryllium is an adrenergic neuroblocker used as antihypertensive in case of withdrawal, and parenteral use facilitate reversal of ventricular fibrillation. Mechanism action is early release and later inhibition of sodium release, potassium channel blockade. It prolongs action potential duration, effective refractive period. Dofetilide is a pure class 3 anti-arrhythmics, selectively block rapid component of delayed rectifier potassium current. No other channel blocking actions are seen in the drug, and no increase in mortality even if patient the high risk of sudden cardiac death and MI. Less arrhythmogenic, Torsades point is seen in less extent and uses to convert AF and atrial flutter to sinus rhythm, mainly to convert rhythm, and is being orally used. Ibutilide is a newer class 3 drugs used as an IV to convert AF and atrial flutter to sinus rhythm. Class 4 drugs are calcium channel blockers. Inhibition of calcium channel mediated slow channel inward current. Dihydropyridines worsens the arrhythmias. Verapamil is the most important drug, and other drugs is diltiazem. Verapamil blocks the L-type calcium channels and delayed calcium recovery. This depresses the calcium-mediated depolarization, leading to also suppresses automaticity and reentrant dependent slow responses. The phase 4 depolarization sinoatrial node, AV node, Purkinje fibers are reduced, leading to the bradycardia and extinction of latent pacemakers. There are also causes delayed after depolarization in Purkinje fibers are reduced. Prolongation of effective refractive period of AV node leads into as a consistent action on AV node, leading to AV conduction is slowed. Re-entry involving the AV node is terminated. Slow rise of action potential, and intraventricular conduction is not affected, has a negative inotropic action due to the calcium blockade, and contraindicated in case of VT. It causes VF, digitalis toxicity, partial heart block, and sinus, sick sinus, reentrant supraventricular and nodal arrhythmias like WPW. Uses, it is used in the PSVT. Treatment is 5 milligram IV over 2 to 3 minutes, and it's contraindicated if accompanied with hypotension and congestive cardiac failure. Also, for prophylaxis, can be used in oral. To control ventricular rate in AF and atrial fibrillation as an alternative or in addition to digitalis. Diltiazem is cardiac action similar to that of verapamil, but is less marked. Used as an alternative to verapamil, and has a rapid control ventricular rate in AF and atrial flutter. Diltiazem is preferred. There's early titration of dose, less hypotension, and myocardial depression can be used even in the presence of congestive heart failure. PSVT, in other drugs like for PSVT, the termination of IV agents can be used verapamil, diltiazem, esmolol, digoxin, adenosine. Adenosine most preferred, and for maintenance oral agents, digoxin, verapamil, and beta blockers. Adenosine, the interaction with the A1 adenosine receptors, G protein coupled receptors, it causes activation of acetylcholine sensitive potassium channels, causes hyperpolarization of membranes. The sinoatrial node, the pacemaker depression happens, leading to bradycardia. AV node, the effective refractive period is prolonged, leading to slow conduction. Atrium, there is shortening of action potential, leading to reduced excitability. Indirectly reduced calcium current in AV node, leading to re-entrant depression of AV node, leading to PSVT termination. Adrenergically induced delayed after repolarization in ventricle is suppressed. Thus, transient coronary dilatation, only rapid administration over 1 to 3 seconds. It available as free base or as ATP. Adenosine triphosphate. Action within 30 seconds in 90% of patients of PSVT of avian origin, AV node origin. It has a very short half-life of about 10 seconds. It is uptaken by RBCs and endothelial cells and converted to 5 AMP and inosine. Advantage is efficacy equivalent to verapamil, duration less than 1 minute, and transient adverse effect. No other hemodynamic changes in verapamil resistant patients can be used in verapamil resistant patients. Disadvantages has to be injected through a large vein, a brief action, not suitable for recurrence cases, and it's expensive. Uses in PSVT cases and diagnosis of trachearrhythmias dependent on AV node to induce brief coronary vasodilatation or control hypoventilation during surgery. Adverse effect: transient dyspnea, chest pain, hypotension, flushing, ventricular standstill for a few seconds, and BF bronchospasm and asthmatics. So agent used for AV blockade like atropine. AV block due to the vagal overactivity. Digitalis toxicity can be used in case of digitalis toxicity. MI abbreviates the effective refractive period of AV node and improves conduction velocity of bundles of phase. Sympathomimetics like adrenal, isoprelin overcome the partial blockade, facilitate AV conduction, shortens effective refractive period of conduction tissues, and to maintain a sufficient idioventricular rate in ill heart block till external pacemakers are implanted. So magnesium acts on sodium potassium ATPase sodium, potassium, and calcium channels, given as IV over a period of 20 minutes and used for termination of ventricular tachyarrhythmias, polymorphic toxicity points, and digitalis induced tachyarrhythmias. Digitalis is effective against atrial arrhythmics. It has some vagolytic effects, thereby slowing down conduction of impulses, but enhances accessory pathways of conduction, leading to digitalis arrhythmias, digitalis tachyarrhythmias. And dose of 0.5 to 1 milligram divided doses over 12 to 24 hours is given. Potassium reduces the conduction velocity, prolongs refractive period, reduces automaticity, and primarily in Purkinje fibers. Hypo and hyperkalemia, those conditions are arrhythmogenics. Slight hyperkalemia protects arrhythmias after cardiac surgery, and untreated hypokalemia increases the risk of delayed after depolarization, early after depolarization, and ectopic pacemaker activity as seen in digitalis. Correction of hypokalemia alone restores sinus rhythm. Ranolazine is a recently approved drug and improves exercise capacity. Probable mechanism of action is inhibition of cardiac myocyte fatty acid beta oxidation, improve myocardial ATP utilization, inhibition of delayed rectifier potassium channels, and inhibition of late sodium channels. This reduces energy required for myocardial repolarization. Adverse effects: nausea, constipation, dizziness, and QT prolongation. Use as second-line treatment and chronic stable angina. So based on this, choice of antiarrhythmic drugs and asymptomatic with a normal heart, not affecting hemodynamics, like atrial extrasystole, ventricular extrasystole, first degree blockade, or bundle branch blockade. No arrhythmic agents are required, and prophylactic therapy with class 1 and class 4. There is no survival benefit seen with the drugs. Vigorous therapy is indicated in life-threatening arrhythmias, those causing hypotension, cardiac failure, breathlessness, in presence of marked palpitation as seen in PSVT, sustained VT, AF, and toxicity points, and arrhythmias following MI. Supraventricular arrhythmias, drugs of choice will be adenosine, verapamil, and diltiazem, and ventricular arrhythmias, lignocaine, mexicillin, and bretillium. In case of both, amiodarone, beta blockers, diazopyridine, and propionamide. Summary of the class. So class 1, the decreased slope of phase 0 depolarization, class 2 decreases slope of phase 4 channel, and class 3 is a potassium channel blockers, and class 4 calcium channel blockers. Thank you.
Madam.
So the forum is open for discussion. Aswant, I want to know what is arrhythmias. Definition of arrhythmias.
Abnormal conductions as in the heart because of either due to atomicity or because of conduction or conduction abnormalities or both.
So any change in the heart rate, rhythm,
Yes.
or conduction system is defected. That is known as arrhythmias, right?
Yes.
And you have discussed well regarding different kind of the arrhythmias and treatment. So how old you are in cardiac anesthesia?
In almost a year.
Yeah. So as per your practical experience, which type of the arrhythmias are common?
Post-surgical, we are most commonly seeing junctional ectopic arrhythmias and supraventricular arrhythmias.
In preoperative period?
Preoperative period, we're seen with in case of post for CABG patient, we've seen LVB is patterns are seen.
Mm-hmm. So you are doing the maximum CABG cases.
Yeah, we're doing a lot of pediatric cases and equal number of CABG cases.
So in pediatric age group, what kind of the arrhythmias are common? What about sinus sinus tachycardia and sinus bradycardias?
Sinus tachycardias are more commonly seen in pediatrics.
So do you think sinus tachycardias has to be treated?
Asymptomatic in the sense like there's no hemodynamic instability, not be treated, but rate control can be done.
Rate control can be done. So what are the causes of the sinus tachycardia and sinus bradycardia?
One preoperatively, one is demand supply. So increased demand increases tachycardia.
No, we divide the pathological causes and physiological causes in these phases on that basis. No? Sinus bradycardia, we say in athletes, pathological jaundice patient, right? When the bilirubins are high, there may be sinus bradycardia. It affects on the SA node.
Yes.
In hypothyroid patient, there might be sinus bradycardia.
Yes.
In anemia, there might be sinus tachycardia. So these are the common morbidities which are going to create the problems in the rate. So these kind of the rate changes, do you think it has to be treated or it should be taken as an acceptable values?
Not acceptable, ma'am. We have to treat the cause for this. If it's an anemia, we have to treat the anemia cause. So that would reduce the tachycardia. In case of bradycardia, you have to treat the primary cause, ma'am, because if cause is impingement on the synovial node, you have to release the synovial node only through surgical procedures.
So I will give you an example. There is a case posted for mitral valve replacement, right? Patient was having mitral stenosis and her bilirubin levels were high around 4 to 5 milligram percent direct bilirubin. And patient's rate was around 58. So what kind of the treatment should be given in this case for the sinus bradycardia? Because cause is related to mitral stenosis and mitral valve replacement has to be done. Otherwise, it is not going to get treated.
Yes.
The cause is different, liver congestion. So what is your opinion regarding this?
We have to accept sinus bradycardia present because
You
we
have to accept.
except because we are inducing tachycardia or increasing the rate of heart rate, it will cost more worsen the mitral stenotic lesion.
Mhm.
Accept and switch for surgery.
And patient of mitral stenosis is coming for mitral valve replacement is having anemia. So that patient might have the sinus bradycardia or the rate will not change because of anemia, hyperdynamic circulation. Can it be?
Tachycardia will happen, but
So in anemia, there is a hyperdynamic circulation. You agree for that.
yes, ma'am.
But in a case of mitral stenosis, what happens?
Fixed output reaction. So not able to compensate for the anemic result. So
Mhm.
tachycardia will worsen the LV.
Mhm. So is there any change in the rate or may not be?
May not be changed. Right?
And if it changes, then we have to control with beta blockers.
Yes.
Hmm? Beta blockers can be given na, in this case. Yes or no?
Yes, ma'am.
Yes. Okay, fine. And what is your experience regarding adenosine?
We have given only one patient during my duty. Other than that,
You have used it for what?
supraventricular tachycardia. We are given adenosine
Mhm.
to put a large.
Okay, what about amiodarone?
Yes, ma'am. We have been using globally.
You have used amiodarone quite frequently. How you used?
Used as infusion.
Infusion, no bolus. The bolus followed by infusion.
Followed by bolus, followed start then an infusion dose.
So what is the bolus dose?
Dose in adult case will give 150 milligram. If the
Mhm.
pediatric dose will start at 5 milligram per kg body weight and start
Mhm.
as infusion. Infusion in adult case
Mhm.
is usually based on the rate we start like 80 milligram per hour over
Mhm.
24 hours.
Mhm. So the drug should be used for 24 hours, right?
Yes.
Okay, fine. Any other antiarrhythmic you have used in the theater?
In fact, like mostly on post surgery, we have seen a lot of cases of junctional ectopics in the pediatric case. So we have
Mm-hmm.
treated them with magnesium and potassium correction. After them, electrolyte corrections have treated the arrhythmias.
What is the dose of magnesium?
Ma'am, 25 to 75 milligram per kg body weight, up to 75 milligram.
One ampule contains how much?
Sorry, ma'am.
One ampule contains how much?
1 ml when it's 500 mg.
500 mg. And you give IV directly,
No, ma'am, through infusion.
infusion. So how you prepare the infusion?
Diluted based on the drug, we give around 20 ml of infusion over 20 minutes we give.
Okay, fine. No more question from my side. If anybody wants to ask anything, is most welcome. Rahul,
Now, sir, had exited from the meeting.
Acha, he has exam. Okay. Then who are the senior people with us today in the meeting? Let me check. Uday, you want to say something? Deepak sir. Okay, I think so. Good discussion and good presentation. So can we end up the meeting? Manoj,
Yes, madam. Yes.
okay?
Yes, madam. Yeah.
Okay, fine. So thank you very much once again to you all, and we are ending the meeting.